Um, Good morning, good afternoon, good day. So today we will talk about PTLD, and we have Dr. Agha. Like always, his teaching caliber and skills are incomparable, as Dr. Kamar just mentioned. So just in the background, PTLD, as you all know, post-transplant lymphoproliferative disorder. So we see this a lot. I have seen this myself a lot, but recent years, I would like to share one observation that the kind of incident, I've seen some prevalent patients who I continue to follow who have recovered after treatment, but I've also seen a decline in the incidence, and that might be my own personal experience or lack of too much exposure. So I'm really interested to see as what's happening in today's world with the modern immunosuppression and all that. So as you all know, this is the echo, the vision is the all teach, all learn. So please feel free to stop or ask questions. I know that Dr. Agha doesn't mind, even if you ask him questions in the middle of the discussion, although it's always best to ask questions in the end, but I think it generates a lot of discussion while you are at a particular topic. And please feel free to share your own experience with patients in the end, your cases. So without further ado, Dr. Agha, all yours.
Thank you very much. Let's first of all, let me apologize for the delays and ups and downs, but hopefully we'll get back on schedule now. So I'm going to be let me just start by sharing my screen here. So let me start
I don't know if your mic changed, because all of a sudden the voice quality changed. So you want to make sure that you use the mic. Okay.
Can you hear me better now?
Yeah, it's okay now.
Moved it away from me. All right, and can you see my title slide, the EBV picture?
Yes, we do.
All right, very good. So this is a very, very difficult topic to talk about. It's a discipline in its own self, and it is not a discipline which is directly related to what we do. We are nephrologists, we are not oncologists. And once PTLD develops, it's actually a cancer or a cancer-like syndrome in most cases. And therefore, we have to work very, very closely with our oncology colleagues. But from our perspective, and the most important thing we can do is to never to see it. And this is kind of what dovetails into Umar's observation. The incidence of this in solid organ transplant patients has gone down actually. And that is because we have started reacting to EBV viremias in patients who are at high risk for PTLD, and we'll talk about that a little bit. So before we go on, this is a CME talk. I have no relevant disclosures for this talk. My disclosures are already on file with ECHO, and I don't have any patient cases today, but as is my norm, if there are any patient references, they would be de-identified and modified to maintain anonymity. And so PTLD is a proliferation of lymphoid or plasmacytoid cell lines. So that's kind of the crux of the matter. There's a proliferation of cells. And this happens in immunocompromised state due to either solid organ transplant or bone marrow transplant. So in a transplant patient who's immunocompromised, if you're seeing a proliferation of lymphoid or plasmacytoid cell lines, under the right circumstances, that can be labeled as PTLD. So you can see this is a very, very broad and general definition. So we will add some nuance to this as we go along this discussion today. EBV association in PTLD disorders is frequent, but it is not mandatory. So you can have PTLD without any EBV reactivation, and we'll talk about it. But most of our PTLDs that we see are B-cell neoplasms, and most of them are related to EBV. So we will spend quite a bit of time today talking about the virology of EBV. We'll spend some time talking about biology of EBV-driven PTLD. And then we'll get to the nitty-gritty. How does it present? What are the various presentation syndromes? And we'll kind of keep a little bit of a 30,000-foot view on that, because there's so many different types of cancers which slightly different presentation, so I didn't want this to become a roll call of those. Then a broad view of management strategies, and we'll spend the last 5 or 10 minutes or so of the talk talking about prevention, because this is one of those disorders where you actually never ever want to make the diagnosis. You want to cut it off, you want to preempt it, you want to never see this. If you're seeing it, you're probably late. So Epstein-Barr virus, which was diagnosed in, not diagnosed, identified in 1964 in a Burkes lymphoma cell line, is a gamma herpes virus. And like all the herpes viruses that are pathogenic to man, it finds latency. So this is the default evolutionary mechanism of Epstein-Barr virus. It of the herpes viruses, I'm sorry, they find latency in nerve cells, in B cells, wherever they can, they would hide and evade the immune system. And that makes them very successful pathogens. For instance, about 90% of mankind has been infected by Epstein-Barr virus, but 90% of mankind is not dead. So it finds a way to live in the host, persist in the host, and not kill the host. And that's what we were talking about before we started the talk today, that the COVID virus is actually getting smarter and it's not killing its hosts that much, and is learning to live with them so that it can keep going on, because that's what the evolutionary drive is. And Epstein-Barr virus can cause disease as well as cancers in the immunocompetent patients as well as in the immunocompromised milieu. So since we're talking about post-transplant lymphoproliferative disease, we will start with the biology of the Epstein-Barr virus and then segue into how this causes problems in the immunocompromised milieu. So this is what the virus looks like. It's a classic enveloped virus. So you're going to see this envelope with glycoproteins sticking out. These glycoproteins, like the thorny little things you're looking at the scanning electron microscope rendition of, are the things with which the virus feels its surroundings and makes certain interactions. Then there's the tegument, which has several glycoproteins which help with target homing in and other reactions. And then you have the nucleocapsid, which hides the viral gene. The viral genome is 172 base pair double-stranded DNA linear genome. And so there are several important proteins that this genome codes for, which leads to division of the virus and creation of progeny. EB nuclear antigens, which are multiple different types, 1, 2, and then 3 subtypes of 3, late membrane proteins of 3 different types. And these QPs, CP, WPs, these are the promoters, and these run different programs. So if you're engaging the CP promoter, a different sequence of protein generation would ensue, mutatis mutandis. If WP or QP are being engaged, then you'll see a different program. And we'll talk a little bit about that, but we're not going to go too much into genetic control. That takes us too much into the weeds of the microbiology of this thing. So this is kind of a big picture view of what happens. So we're going to distinguish between the primary infection and then persistent infection. And this is a very wide virus. So the virus comes in, it's the exposure in the human bodies to the saliva. So it comes in, it breaches the oropharynx lymphoepithelium, and we'll see how that does. And it goes and finds resting B cells. Once it finds the resting B cells, it engages the resting B cell. It can lead to what is known as a lytic cycle, where all the antigens are turned on. The virus drives this B cell to death, generates a bunch of progeny viruses, and they infect other cells. So this is not a smart way of doing this, right? Because it's going to kill the host if this goes on. So very quickly, the virus says, okay, I'm here. I've got my feet wet here. I'm settling down. And it starts turning on several programs called the latency programs, and we'll go over those. And eventually turns into a memory B cell. And this is a fascinating use of the host's own immune response, in which this EBV, which was sitting in the saliva, finds itself in a stable state inside memory B cells. And then these kind of cycle back. Sometimes they will go into a lytic phase. Sometimes they'll reactivate themselves and divide. But once they reactivate and divide, they are then very, very susceptible to the host immune response, and the cytotoxic T cells, natural killer cells, can take these out. So this primary infection establishes them in the memory B cells. And then persistent infection is usually in a stable state with intermittent lytic cycles, so that person may actually periodically become EBV DNA positive and throw some virus out in the saliva. But if it gets too ambitious, the host immunity can take it out. So this is the large big bullet infection cycle. Now let's kind of delve a little bit deep into this, because the devil is always in the details. So this is the Waldeur's ring: adenoids, lingual tonsils, palatine tonsils, adenoids, lingual tonsils, tubal tonsils, and palatine tonsils. So this is the ring of lymphoid tissue which is in our throat. Now, if this is the saliva interface and this is the surface epithelium, there are germinal centers which are sitting right underneath the surface epithelium. A high epithelial endothelial vesicles are little in the through which be back in, come in and sit on, and then there's an antigen exposure. They drive the B cells into the germinal center, and there's a whole sequence of events that happens. But this is how, not just EBV, this is how the immune system samples a lot of antigens that are coming in through the mouth, food, saliva, so on and so forth. Now, once EBV comes in and touches the epithelium through this, we're talking about the lymphoepithelium on top of the lymphoid tissue in the Waldeur's ring. It engages various surface molecules, so the GH and GL molecules, along with the BMRF2, which toggles the various integrins on top of the epithelial cell. It goes into the epithelial cells. It is unclear whether an epithelial cell infection is necessary. Sometimes they can zip through some vesicles. Once now they get into the subepithelial space, they will find a naive B cell, and we'll look at a couple of cartoons in a second. So the naive B cell has CD21, which is the CD3 receptor on top of it, and MHC2 molecules. So GP350 on the Epstein-Barr virus, one of these little spikes, is going to attach to CD21. GP42, another one of these spikes, is going to attach to the MHC2 molecule on top of the naive B cell, and that leads to a sub-receptor reaction, and the EBV genomic material gets inside the B cell. So let's take a look at this again. This is your lymphoepithelium. The crypts are pretty deep, and at this point, the lymphoepithelium may be just a cell thickness thick only. So the virus, any antigen, in this case the EBV, gets into this mantle zone. These blue little circles are virus naive B cells. The virus infects them, walks them through certain stages of development, which we will talk about, and then this latent virus, which is of a memory B cell phenotype, goes into the circulation. Now, it can come back through these HEVs in the endothelium, get back into the Waldeur's ring epithelium, as well as other secondary lymphoid organs, and can periodically turn lytic or cycle back in. So EBV can stay inside the host forever. And that's where the story ends for pretty much everybody, unless you happen to be unfortunate to develop a specific mutation, to develop a lymphoma, or you are immunosuppressed because you needed a transplant. So let's take a look at it, look at the complexity of how this happens. Now, on the left side is a simple antigen. This antigen comes in through the saliva, gets through the surface epithelium, and then gets into the mantle zone where the naive B cell is going to pick it up. Now, when the antigen is picked up by naive B cell, this cannot undergo this activation phase itself. If you remember our talks from immunology of allorecognition, what happens here is that this naive B cell, which has now gotten exposed to an antigen, would need help from a T cell called a T follicular help cell. So it's a specific phenotype of a CD4 cell. And this then leads to proliferation of the naive B cell. It undergoes rapid multiplication and enters what is known as the germinal center reaction. And in the germinal center reaction, the B cell receptor repertoire is finalized. It undergoes somatic hypermutation, it undergoes class switch, and eventually comes out with two phenotypes. Either it turns into a plasmablast and then becomes a plasma cell to check out antibody, or it comes out as a memory B cell. Memory B cells continuously circulate into the lymphoid organs, and if they find cognate antigen, then they would immediately have a reaction, turn into plasma cells, plasmablasts, and then plasma cells, and lay out sheets of antibodies at a 24 to 48 hour notice. So for all this, you need various components of the immune system to engage. Now, what happens with EBV is fascinating. So what now is happening is you've got the EBV coming in, it's picked up by the naive B cell. This circular episome is now your EBV genome inside the B cell. Now, as soon as this happens, it starts opening up production of the various proteins, the eDNAs and LMPs and so on and so forth. And those proteins themselves actually can provide the stimuli that the T cells were providing these canonical B cells to mature. So actually EBV takes over the entire immune processing protocols. And so this cell is pretty much on its own. The EBV is going to produce those stimuli to cause it to undergo the germinal center reaction, somatic hypermutation, class switch, and then the memory B cells that come out actually have EBV in them. And the plan that the virus has is that it will stay in these memory B cells forever. And how we know that happens is that it's actually generating a very specific latency program. So when
Dr. Agha, I'm sorry to interrupt at the, so I got a chat message that something happened to the voice quality from your mic again, and it dropped. I don't know if this is internet connection issue or microphone issue.
Can you hear me now?
I hear you. Let me ask the other participants if they are able to. Hina, you sent me the message. Are you able to hear him now? Anybody else has any other difficulties with the voice? If not, then we will continue.
It's coming from very far away. I think it's there, some echo in it or some far away thing.
So she said yes, maybe. I think it's working now.
Yeah, it went away for a little while, लेकिन वो खुद ही ठीक हो गई थी मेरे ख्याल है within 15 seconds it became okay. So I think we continue.
Sorry about that. Please continue.
My internet connection. I got a hardwire this. I think Wi-Fi gets into trouble from time to time. Okay, so where were we? Okay, so now the virus. So there's different programs that the virus goes into. The latency-free program or the growth program is when the B cell gets into the germinal center, all proteins are expressed, and this is the time when the virus is replicating pretty fast. The default program or latency-2 program is when it starts slowing down, decreasing the expression of these proteins, and then it goes into latency 1 and latency 2, where very few proteins, just the eDNA1, may be on the surface of the cell, which helps it evade immunity. So the virus's design here is that it will try to stay there without attracting any attention to it. So these programs are interesting to remember because very specific problems in these programs lead to various types of lymphomas. And so this is the grand design, the grand scheme of how this happens. EBV comes in, engages the growth program, makes these B cells replicate, then it starts turning this into the memory B cell direction and engages the default or the latency 2 program and the latency program, and then the eDNA1 program only. So these cells are in a pretty quiescent state. The EBV DNA is sitting in them and it is just riding around. Now these cells, because these are memory B cells and they carry out immune surveillance, from time to time will come back through the HEVs into the lymphoepithelium, and at times, due to factors that are not completely known, can sometimes switch back into the lytic cycle and release EBV into the cells or go back into the quiescent state. And this continues forever. Now, the body is not looking at it from a neutral position. The body is trying to keep this thing under check. So once these cells, so this is again the naive B cell, which runs the latency or the growth program, and then the latency 2 or quiescence and latency 1 and further quiescence programs. These cells can be identified with these different proteins that show up on their surface, and the natural killer T cells, the natural killer cells or the gamma delta T cells can actually surveil them and knock them out. So the immune system keeps all of this in check. And we learned about the gamma delta T cells when we were talking about cytomegalovirus the last time. So in all these phases, there's immune surveillance, which either takes the form of neutralizing antibodies. So if the antibody has been produced, it will take care of the infectious virus and remove it from equation. If there's a new infection, which is the growth program or latency 3 program, cytotoxic T cells actually knock it out. Differentiation program is again susceptible to cytotoxic T cells as well as natural killer cells as well as gamma delta T cells. These actually then go to the peripheral pool and latency program where they're actually sort of protected. But if they start acting up, cytotoxic T cells, natural killer T cells can take them out. If they start replicating, cytotoxic T cells can take this out. So you can see that both the antibody and cell-mediated arms of immunity and both the adaptive as well as innate parts of the immune system are keeping this in check. Otherwise, you may run into uncontrolled EBV replication as well. And that kind of starts setting up the thing on what happens when you're immunocompromised. So when you get the infection, there's a variable incubation period, and then an acute phase comes in when people start getting symptomatic. So when somebody comes to you with infectious mononucleosis, they've actually been actively infected already for about 4 to 5 weeks, right? And so you start getting the various antibodies, wild capsid antigen, eDNA antibody, et cetera, after variable periods of time. IgMs go down as class switch happens, and the various different types of IgGs are present in the blood. The Epstein-Barr virus nuclear antigens and DNA go down as the infection is controlled. Now, when we see these patients in our clinic and we check their serologies, this is what we are looking at. Serologic evidence that there was an acute infection at some point, and this acute infection is now under control. There's no EBV DNA, there's no IgM, but we have these IgGs which are there to provide long-term protection in case the virus starts picking up, right? So how does that segue into our patients? So we're going to go through this picture from left to right. Now there's 2 ways in which our patients, that is patients who are immunocompromised either due to a bone marrow transplant or because of kidney or heart or liver or pancreas or lung transplant, right? So the EBV that can be coming in could be through the infection that happened when they were a child or when they got mono, or it could come in because the virus was transmitted to them. They're negative, but the virus was transmitted to them through the graft. Now, in adult patients, this is rare. This is more common because most of the adults that we see, 80 to 85%, have serologic evidence of previous EBV exposure. On the other hand, the patients that Dr. Lane-Walla sees, they actually may be infected primarily through the graft because a lot of kids, a higher proportion, not a lot, but a higher proportion of kids actually may not have been exposed to EBV, and therefore they could get infection either which way. Now, once the infection comes in, they come in and attack the naive B cells, which are here in yellow. And this is controlled by natural killer cells, which are part of the innate immunity, CD8 and CD4 T cells, which are part of the adaptive immunity. And they try to control this. Now, the B cells go into the latency phases. So they go through the growth phase and the latency phase. And the EBV is now existing in these cells as an episome. Again, the various arms of immunity are trying to control this. But when you have the patient under immunosuppression, this may not be effective, and you will have some proliferation of these cells, which may actually manifest as viremia from time to time. And once this viremia settles in, now what you need is something else. Because if you really think about it, if somebody is going to develop EBV because the immunosuppression is not is rendering the immune surveillance ineffective, what you should see is a polyclonal increase in B cells, right? This should be like an acute infectious mononucleosis type syndrome, and in many cases, that's how it starts, especially in children. That's how it starts. But then something else needs to happen. And that something else is specific mutations that can happen in different parts of the growth program and the latency program, etc., where the cells select out for clones that are going to divide on their own. So you're now leaving the immune response or dysregulation of that because of immunosuppression to a point where certain clones are going to take over. And that's where either an oligoclonal or a monoclonal process starts, and it starts migrating towards cancer. So that's the milieu of immunosuppression is the permissive milieu in which the EBV proliferates, finds cells that have a problem, and then can lead to a certain cancer. So let's take a look. Now, this is what happens in Burkes lymphoma, right? You've got EBV, it attaches the B cell. Now, this is the germinal center. There's this stuff going on here, and suddenly what happens is that the c-MYC gene, which is an oncogene, translocates with the immunoglobulin gene. And now suddenly you have development of a lymphoma because now this is an oncogenic stimulation of division, and this then turns into Burkes lymphoma. And you can actually see that the type of cell that is susceptible to this is running the latency 1 program. So it's got EBNA on the surface, and this cell is now dividing in a monoclonal fashion. And this is what Burkes lymphoma looks like from a genetic standpoint. On the other hand, if you have a problem with the immunoglobulin variable gene mutations, right? So in this particular situation, when the cells are running the growth program, the latency 3 program, where all these things are being expressed, there's a problem in the immunoglobulin variable gene mutation gene, where there are some destructive mutations that happen. And what this happens is it cripples the B cell receptor, and you start developing these Reed-Sternberg cells. That's what defines Hodgkin's lymphoma. And if you look at what program these cells are going to be showing, so if you do molecular analysis, you'll see EBNA1, sometimes 2 and 3, LMP1, LMP2A, LMP2B. So this is the latency 2 program that these cells are running. And this happens in the growth phase of these B cells. Now, post-transplant lymphomas are another factor. All of these can be seen in the post-transplant milieu, but post-transplant lymphomas themselves are heterogeneous. Their cellular derivations can be very variable. And so what we see here is either somatic hypermutation or problems with immunoglobulin rearrangements. And you can see a whole soiree of different cells with different programs, but usually the growth program that is seen on these cells. And then this is angioimmunoblastic lymphadenopathy with dysproteinemias, and we're not going to talk too much about this. So the important thing is, if you're getting a problem in the growth program, you're going to see immunoblastic PTLDs. If you're seeing a problem with the default program or the latency 2 program, you're going to see Hodgkin's disease. If you're seeing a problem in the latency 1 program, which is the EBNA1 only program, you're going to see Burkes lymphoma phenotype. So just by analyzing the cell surface markers, you can see the various places where the EBV is manipulating the cells, but with specific mutations that come along the way, it can lead to different types of cancers. So with that background, we come back to the definition of PTLD. It is a proliferation of lymphoid or plasmacytoid cell lines in an immunocompromised milieu due to transplantation. And then we have just talked about EBV. There are other complex mechanisms through which cancers may happen, but since EBV is more common, I kind of spent a little bit of time talking about it. So this is what PTLD is. Now you know how it develops through a simple EBV infection to a life-threatening complication. So the WHO looked at all of this and said, okay, let's put these in little boxes. PTLD generally is divided into destructive and non-destructive. Now, the destruction part means that the cytoarchitecture of the lymph nodes or the immune organs like spleen, liver is not being destroyed. So there's infiltration of cells, but it's not being destroyed. So the non-destructive PTLDs are the ones that we used to call early lesions, but we don't call them early lesions anymore because that confuses. Is an early lesion in the first year or is an early lesion based on morphology? So we call them what they are now. So there's 3 different buckets of non-destructive lesions. We'll talk about them. Then there is a bridge between non-destructive lesions and frank lymphomas, and these are polymorphic lesions. And I'll talk about what polymorphic lesions are, and then we come on to hardcore lymphomas, which are usually monomorphic. So non-destructive PTLD, 3 different types, and these are early in the sense that they are early in the journey of the B cells graduating towards lymphoma. They do not disturb the lymph node architecture, and they classically, these present in lymph nodes, tonsils, Waldeur's rings, and that's where some problems happen. And we'll go over that. So plasmacytic hyperplasia usually is a lymph node disease. Florid follicular hyperplasia is actually indistinguishable from other follicular hyperplasias, but it sometimes can lead to mass lesions. And infectious mononucleosis PTLD affects the lymph nodes, and tonsils, and adenoids. In all of these, there can be gray zones. Like so, for instance, there's a transplant patient who comes to you. He says, my tonsils are enlarged. There's EBV in the blood. Is this PTLD or not? And depending on, you know, how many EBV cells there are inside that lesion, if it's less than 15 per high power field, it probably is not PTLD. Most people will not call it. If it's more than that, it probably merits being called a PTLD, but you can appreciate that there's a little bit of a gray zone on these. But these are milder lesions, and these are lesions that actually can respond quite well to reduction of immunosuppression. Now, Polymorphic PTLD is the bridge gap, right? So the polymorphic look is based, or the designation is based on cell morphology. The cells are of different shapes and sizes. They're in different stages of development. But with modern molecular techniques, sometimes it's possible to find clonality. So therefore, there may be a gray zone between polymorphic PTLDs and monomorphic PTLDs on one end, where there may be a monomorphic PTLD hiding inside a polymorphic lesion, and also between a polymorphic PTLD and IM PTLD, for instance, in the tonsils. Now, polymorphic PTLD is usually seen in children. So Dr. Lane-Muller probably sees much more of this than we do as adult transplant nephrologists. And it is very frequently associated with primary EBV infection, and it is seen early after transplant. Now, monomorphic is where you're kind of looking at the full force of the disease. How is
शादी का नंबर भी मेरे पास है और
I think there's somebody's mic is not off. All right, thank you. Now, so monomorphic lesions, now these are defined as destructive lesions, right? So we talked about the non-destructive lesions. The destructive lesions, just like polymorphic lesions are destructive lesions as well. But in this particular situation, the proliferating cells are monomorphic. And they do fulfill criteria for a typical lymphoma as seen as in an immunocompetent host. So this is how monomorphic PTLDs are broken down. There could be B-cell PTLDs or T-cell PTLDs. And in the B-cell PTLDs, there could be diffuse large B-cell lymphomas, which are, from the growth program, Burkes lymphoma, which is the latency 1 program, plasma cell myelomas, and plasmacytomas, which are from the latent programs. And then T-cell PTLD could be peripheral T-cell lymphoma as well as hepatosplenic T-cell lymphoma. And then there's buckets in each of these for other lesions. These can be very diverse lesions, and sometimes it's very hard to put them in a bucket. So what are the risk factors as clinicians? What do we worry about? The first thing is type of transplant. If it's a bone marrow transplant, the risk is higher. If it's a kidney transplant, the risk is lower. I think EBV serostatus is extremely important. If you're EBV naive and you get a transplant, either a bone marrow or a solid organ from an EBV positive donor, you're going to get into trouble. You're at the highest possible risk. The type of immunosuppression, use of depleting antibodies like thymoglobulin, especially in the bone marrow sphere when they're treating graft versus host disease, confers a higher risk. Tacrolimus and cyclosporin, probably about the same amount of risk. MMF and steroids are more or less neutral. Belatacept got a black box because in EBV naive patients, if you put them on belatacept, their risk for PTLD goes up. So you're not supposed to use belatacept in EBV naive patients. And the strength of immunosuppression matters, I think. There was a trial which was using tofacitinib, which is a JAK inhibitor, and they needed to adjust the study because of PTLD risk in the highest strength of immunosuppression arm. So we have to be careful. So we have learned to identify patients who are going to be at high risk of PTLD. These are the patients where you probably don't want to use depleting antibody and keep the maintenance immunosuppression appropriately low. And then there are certain host factors: white race, young age, predisposed to PTLD. So this is a risk analysis based on the type of organ that we're talking about. So your risk is highest if you're doing hematopoietic stem cell transplant or multi-organ transplant or intestinal transplant, 3 of the highest possible risks because the degree and level of your immunosuppression is high in there. And then lung, heart, liver, pancreas coming down, and luckily kidney, the risk is perhaps the lowest, but it is not zero. And if you see one patient with bad PTLD, you've seen enough. Now, when I talk about clinical manifestations, we'll kind of try to tease out 2 large spheres of presentation. One is early PTLD, which happens in the rough first 1 to 2 years after transplant. These are usually EBV positive B-cell PTLDs. And then there's late PTLD, which is more than 1 to 2 years, usually EBV negative B cells or CNS PTLDs or non-B cell PTLDs. So the late bucket keeps going up slowly over a period of time. The first spike that we see is usually B cell PTLDs, and these are the tumors that are following the script. You've got the highest risk patients with high immunosuppression, maybe EBV zero risk, and within the first year, first 18 months, you'll see a lymphoma crop up. Late PTLD comes in after the first few years, and mostly these present slightly differently, as we see. So now you've got somebody where you're suspicious that there may be some EBV type things going on. So you run some EBV specific tests. Serologies are useless apart from ascertaining risk at the time of transplant. So we don't use serologies to diagnose acute EBV infection anymore. EBV PCRs, quantitative PCRs, peripheral blood quantitative PCRs is what we use. And then now we're starting to understand the importance of cell-free DNA, EBV cell-free DNA in peripheral blood, which can actually give us a much better handle on the burden of EBV inside the peripheral blood, and you can follow that as well. Once you're suspicious that there may be PTLD going on, you want to image them. Traditional imaging is whole body CTs, and then PET scans have come in and helped in a big way. So in our practice now, we do PET scans, and then we do staging PET scans as well. It confers a lot of radiation, but gives us a lot of definition. Tissue diagnosis is important. We'll talk about some things about biopsy handling, which you may want to discuss with your histopathology crew. Bone marrow biopsy may be necessary in many cases, almost all cases. And then targeted investigations based on presentation. And these are usually the late PTLDs, where if it's a GI presentation, you do endoscopy, CNS presentation, you do extra CNS imaging, lumbar puncture, et cetera, et cetera. So type of and diagnostic considerations are modified based on what you're looking at. Now, when you are doing a biopsy, if you're biopsying a lymph node, you want an excisional biopsy if possible. Sometimes you'll get an aspirate, and that doesn't help that much. We need detailed histopathological and immunophenotypic evaluation of these cases. And you need to be able to do an EBR in situ hybridization, and we need to be able to run some molecular and genetic testing. I don't know what the capabilities of our labs are in Pakistan, but I think even if you don't have a lot of this, if you've got a good diagnosis and if you can develop chronality and kind of put them in the right ballpark, you'd be able to get them to the right treatment. So in the immunocompetent patients, we know that usually lymphomas present with nodal presentation and lymphoid organ involvement, lymphadenopathy, hepatosplenomegaly, and so on and so forth. PTLDs up to 2/3 could be extranodal, and the extranodal presentations are diverse. So if you've got to have intragraft lymphoma, that happens within the first couple of years. CNS and GI can be several years removed. So CNS 2 to 7 years, GI 6 to 10 years. There can be EBV positive mucocutaneous ulcers. Children, on the other hand, present early, and they can present with head and neck involvement, so they'll have lymphadenopathy and tonsillar enlargement and so on and so forth. So the presentation in the transplant patient can be quite different. So there was this large study which was done in Switzerland, I guess, which was a nested project based on data from multiple transplant centers throughout Switzerland, and they gathered data for about 10 years on these patients, and they had close to 5,000 patients that they looked at. Out of those, they found about 57 PTLD cases, and only 1/3 of these presented with nodal presentation. 2/3 were extranodal. So, they may just present with diarrhea. They may present with CNS presentation, then that's PTLD too. Now in children, it's a little bit of a different animal, and we'll go over it. And if Dr. Lanewell is online, we can ask him for his experience as well. And when we talk about extranodal, it could be CNS, abdominal organ, liver is very common, intestinal, bone marrow involvement, as well as the transplanted organs, so liver or kidney. Heart's probably the only one where it doesn't happen that much. Now, EBV positive PTLD, which happens earlier within the first 1 to 2 years, presents in children like a severe mononucleosis syndrome, to a point that sometimes they develop HLH, hemophagocytic lymphohistiocytosis. So it's that severe with a sepsis-like picture and so on and so forth. In adults, even EBV positive PTLDs present a little bit more gradually and with some nodal and extranodal manifestations. Most of the EBV positive PTLDs are B-cell proliferative lesions. EBV negative PTLDs are usually T-cell proliferative lesions. And then gene expression, can be dependent on the stage, but usually it's non-germinal center B-cell, whereas EBV negative PTLDs are germinal center B-cell phenotypes. EBV positive PTLDs are more common, they're early, in bone marrow transplants, they are almost exclusively B-cell neoplasms, EBV positive. So in solid organ transplants, we can have about 30% of PTLD negative for EBV. So now you've got somebody who has been 1 year out from a transplant, and they come to you with fever, and they've got a little bit of lymphadenopathy, and you image them, and they've got an enlarged liver, enlarged kidney, you biopsy them, and you find a monomorphic population of B cells in there. So what do you do with them? So there's many different magisteria of treatment. The first is reduction of immunosuppression. This is something most of the early, and when I say early, I mean early ontologically, not early timing wise, lesions respond to. So we discontinue the adjuvant agent, although there's really no evidence that MMF or AZA makes things worse, but we're trying to reduce the overall burden of immunosuppression. We reduce the calcium urine inhibitor dose to half, or switch them to mTOR inhibitors. My practice is to switch them to mTOR inhibitors, so I keep them on mTOR and steroids and get rid of MMF and TAC and cyclosporin. Now, obviously, we worry about rejection, so we want to get a baseline cell-free DNA. If there's infiltration of the graft with tumor cells, your cell-free DNA may be high, but you can then monitor sequentially, especially when you're reducing immunosuppression. What you're hoping for is that the cancer cells will start reseeding, and your cell-free DNA will go down if it is up. But if the cancer is progressing, or if there's breakthrough rejection, your cell-free DNA signature would go up. You monitor renal function very closely, and you might need to biopsy, and it may become very difficult to tell rejection from tumor infiltration in some of these cells. And then we monitor the lymphoma. Quantitative EBV PCR is a very good tool. Now, these things work fast. So once you're reducing the suppression, you're not going to wait 6 months to see what's happening. In 2 to 4 weeks, you will have to restage to see if it's working or not. And there's a fairly good response in early lesions. And again, early lesions, early ontologically, not time-wise. So that's how you would go around with the first tenet of management, which is reduction of immunosuppression. So the first thing is reduce immunosuppression. Now, the second thing is we want to do some B-cell depletion. So now we say, okay, we've reduced the immunosuppression, but this is a cancer where we might actually get away, we'll get to something more. So in non-destructive PTLD, so the erstwhile early stage PTLDs, or polymorphic PTLDs, or monomorphic diffuse large B-cell lymphomas, lymphoma-like PTLD not responding to reduction of immunosuppression, we can use rituximab monotherapy. So we shoot the rituximab. Now, rituximab also allows identification of patients that can be triaged to what is known as sequential consolidation regimen, or a risk stratified sequential therapy. So let's kind of go over that a little bit. So the first thing is you reduce immunosuppression, you consider rituximab. What is the next thing you do? You've given them rituximab, and then you do a restaging. Again, this has to be done within 2 to 4 weeks, usually 4 weeks. Now, if there's a complete response, what we would do previously in some of these aggressive PTLDs is that we would put them on CHOP regardless, right? Now what we do is we do this, we look at it and we say, okay, if they've completely responded to rituximab, they're probably low risk, and we would just give them rituximab consolidation. On the other hand, if we find that they're not doing well with rituximab, we consider them high risk, and then we'll do CHOP, which is the traditional first-line chemotherapy, but add rituximab to it. So this is what is known as the risk stratified sequential therapy. And I'm kind of flying over this a little bit because this is something that your oncologists would be doing. And we just need to be abreast of it. Once it gets to this stage, it's sort of out of our hands. We've already reduced immunosuppression, we've given it to the oncologists and say deal with it. But this strategy, which is, which has kind of come in vogue in the past 5 to 7 years now, this trial was actually described in 2017 and built up on the PTLD1 trial, which actually looked at this without the R. And this actually does well. So these are the people who were treated with the risk stratified sequential therapy approach. They did okay from a relapse standpoint, and overall survival was about the same, if not better. Infections and mortality because of infection was lower. So this is what this summarizes here. The number of patients, so this is a 2-to-1 allocation. Overall response rates are about the same. Complete response rates are about the same, actually better in the risk stratified sequential, I apologize. And then median survival was about the same. So you're getting away with giving them much less intense chemotherapy. But in patients who don't respond, or in some patients from the get-go, you have to consider chemotherapy. So if you've got B-cell PTLD unresponsive to rituximab and reduction of immunosuppression, you'll consider that. So this is one of the schemes that we talked about in that circumstance. But if you've got a Burkes lymphoma morphology, Hodgkin's lymphoma morphology, or T-cell lymphoma, CNS lymphoma, or other uncommon lymphomas, you'll have to get into chemotherapy, and that's not good usually. So the best outcomes are tumors that are processes that respond to reduction of immunosuppression or rituximab monotherapy. If you get into this stage where you're not responding to rituximab, then the prognosis starts going downhill pretty fast. So there's some other things that have been tried, and most of what we are going to look in the next few slides was tried in the bone marrow transplant realm. So this again is the latency-free program, leads to PTLD and certain HIV-associated lymphomas. And in the bone marrow PTLD milieu, if this PTLD is in the bone marrow transplant milieu, we can find adoptive T cells, different types of T cells that can be infused, and they find this to be the easiest target. This is the most immunogenic latency program. This is the least immunogenic latency program. So we'll just talk about this. That's all we're interested in today anyways. So what they can do is they can pick up peripheral blood mononuclear cells, and they can actually transfuse them, saturate them and transfuse them unmanipulated. So this is donor lymphocyte infusion. This has been tried in bone marrow transplant patients. So the bone marrow donor gives up some more of his blood cells. They're cleaned up and reinfused. So what you're actually giving them is effector arm T cells and mononuclear cells, which are going to go and try to kill the EBV positive cells. So that works, they're effective, but they are T cells and mononuclear cells, so they can aggravate GVHD, which is a much bigger problem in bone marrow transplants than it is in kidney transplants. Now, EBV STs are EBV specific T cells. So now what you're doing is you're actually finding the T cells that are going to be specific for EBV. You clean them up, prime them against EBV, and then infuse them back. So the hope is that they would be more specific against EBV targets and would not cause as much GVHD. And this has been used through various mechanisms in bone marrow transplants quite significantly. And this actually works very well if they're being used as prophylaxis. Now, it takes about 6 to 8 weeks to do all this, to do an ex vivo culture and grow the EBVs and make sure the quality control is right and so on and so forth. When somebody is sick with an acute lymphoma, you don't have 6 to 8 weeks to get those cells, and you need to go. So there are mechanisms being devised now to have what is known as off-the-shelf T-cell therapy, that we can order anti-EBV T cells, order anti-CME T cells as well, and infuse them in patients with PTLD. But that's kind of coming down the line. And similarly, CAR T cells are being used in PTLD patients, but very, very rarely. And in case reports, because in the pivotal studies of CAR T cells, the PTLD milieu was excluded from consideration. So these are the various emerging therapies for PTLD. We talked about EBV-directed cytotoxic T cells and mononuclear cells. So you take cells out, grow them, stimulate them with EBV, make them specific against EBV, then infuse them back. You've got CAR T cells, which are chimeric antigen receptor T cells. You take T cells out, bioengineer their receptor to attack EBV antigens, grow them up, and then infuse them back. Various different types of monoclonal antibodies. We've talked about rituximab, but alemtuzumab, anti-CD52, daratumumab, which is an anti-CD38 plasma cell antibody, etc., are being tried in different types of PTLD. Dendritic cell vaccines are very interesting concepts where you actually either do an injection inside lesions, so cutaneous T-cell lymphomas, increasing the expression of TLR9s and causing dendritic cells to go there and lead to an innate response and also a more robust adaptive response. Or you can actually antagonize CD47 activity. So dendritic cells, if they see CD47, that's all eat me signal, so they then refrain from it. But if you antagonize CD47, then the dendritic cells can go and eat those targets. So there's various different things that are being done, but everything, pretty much everything on this chart, apart from the monoclonal antibody, is either being done in the bone marrow transplant world, or we have not fully embraced it in the solid organ transplant world, at least in the kidney transplant world at this time. So for us, the important thing is, how do we prevent PTLD, which is very important. Once you have PTLD, you're already done, and you're on a slippery slope of treatment. Not that everybody is going to have a bad outcome, but then you've lost the initiative. So the most important thing is planning and monitoring. So when I look at serologies at the time of transplant, and if I find somebody's EBV negative, and especially if they're getting an EBV positive organ, I do not do lymphocyte depletion in those patients, because these are possibly a very high risk. So if you do lymphocyte depletion, you're adding very heavy immunosuppression to it. So these patients, if I have to induce, which I almost always do, I use an interleukin-2 receptor antagonist, but I don't use Campath, I don't use thymoglobulin with these patients. Then the second thing, after you've planned immunosuppression to keep the burden of immunosuppression low, is to monitor these patients. So these are the patients where I check EBV every quarter for the first year, and then for another couple of years to make sure that we have covered the first 2 years where these EBV-related PTLDs are going to have the first peak. So once they cross the 2-year mark, then I'm like, okay, I think we're going to be okay here. So if you find an EBV positivity signal in these cases, then we'll see what to do in a second. Now, antivirals, we've all been reading on the legend of acyclovir and ganciclovir. They're both effective against EBV, which is running the lytic program, the growth 3 program. the growth program or the latency 3 program, where all sorts of antigens are being activated, but it can't. These drugs can't act on the cells that are running the latency program. So if there's memory B cells running around, acyclovir and ganciclovir are not going to touch them. So ganciclovir is actually 6 times more potent than acyclovir in vitro in taking the virus out. Both of these drugs need phosphorylation by viral thymidine kinase, which is expressed only during the lytic program. So latent program doesn't have that viral thymidine kinase, and so it's not going to work. Now, foscarnet and cidovovir both are not phosphorylation dependent. That is why they can actually bypass the UL97 mutation in CMV we talked about last time, but they can act on viral DNA only. In PTLD, actually the virus is driving the mechanics of division through the human DNA polymerase. And it is unclear if blocking the viral DNA is going to do anything to the lymphoma process that is going on. So study after study has looked at it. Initially, we thought that acyclovir and ganciclovir help, but I'll show you some trials. One trial where actually they don't seem to make that much of a difference, but we all dutifully have them on anyways because of other reasons. So these drugs are part of our landscape, but it doesn't seem that they do anything significant for the highest risk patients. Now, passive immunization through IVIG has been studied, and again, like the antivirals, doesn't seem to make much of a difference because you give IVIG, it goes up and then it goes down after a period of time. And it looks like the lymphoma genesis process is sustained over a period of time. And so the only thing that works, I think, is viral monitoring and preemptive reduction of immunosuppression. So you got the highest risk person who's got sustained EBV viremia. I would lower their immunosuppression and monitor them very closely and not let them get into the lymphoma stage. And Umer's observation at the top of the talk that the incidence is growing is because we've learned to do that. Previously, we did not know this, but now we can do this, especially in the highest risk patients where the bulk of your PTLD is going to come from, and therefore this works. Now, especially in the bone marrow transplant world, rituximab is used quite frequently now. So you've got somebody at high risk for PTLD and they've got persistent EBV viremia. You don't let them get to a point where they're developing a monomorphic or a polymorphic or a non-effacing lesion. You give them rituximab and get rid of it. And again, like we talked about, in the bone marrow transplant realm, adoptive T-cell therapy has been used as prophylaxis. You get the EBV specific T cells and infuse them, and that restores EBV immunity and gets rid of the problem. So I have used rituximab in a few patients after kidney transplantation where I thought they were at a significant risk due to different reasons, and it actually works quite well. It kills the virus and they've not gotten into trouble, but that's the end of a few patients. Now, this is a study, again, the Swiss study that I alluded to, which looked at the effect of antivirals and rituximab use in subsequent biologic behavior as far as PTLD was concerned. The rituximab in these cohorts was given because the patient needed an ABO-incompatible transplant and they were being conditioned for that, or they had a rejection and they got rituximab because of that. And so then they looked at the impacts. It seems, based on what they found, that the antivirals are actually not doing anything. But people who got rituximab, their incidence of PTLD is kind of extremely low. So it seems that rituximab works, and the hematology people have known this for quite some time, as you can see in this cartoon, that when you've got somebody who's a high-risk patient, you should monitor their EBV. So this is how a hematologist does it, and I think we'll do well to learn from this. And if the EBV titers go up, and if they're very high risk, they'll shoot from the hip and give them rituximab straight away. Now, this doesn't happen very often in our patients. We would probably be in this arm. We'll monitor frequently. We'll reduce immunosuppression responsibly. And if it continues to go down, we will monitor them closely. On the other hand, if there's signs and symptoms of PTLD that develop, then obviously you're kind of on that slippery slope. You'll image them, and if you find a reason, you'll give them rituximab. To be honest, if I've got persistent EBV viremia and I'm getting worried about this, I have a relatively low threshold of going to rituximab. We would obviously reduce immunosuppression. If this doesn't work, we'll give them rituximab. And if there's a localized lesion, we'll do some surgery if it's something that can be taken out, and reduce immunosuppression that way. And if rituximab doesn't work, then this again is mostly being done in the bone marrow space. But I think in an odd case in the kidney transplant space, this can be done. And we've tried EBV specific cytotoxic T cell transfusions. We've tried CAR T therapy in kidney transplant patients with PTLD, but those are case reports and with variable results. So obviously the jury is out on that, on what we can get away with or what would work. But I think the like in BK, the money is to catch this thing over here and not let it get into this corner. So that is the crux of how we look at PTLD driven by EBV today. That's about 70% of all PTLD. If you're unlucky and you develop a non-EBV PTLD, you don't have a monitoring signal, in which case you'll kind of pick it up somewhere around here and then go based on what you're dealing with. So with that, I will stop. I think it's just about an hour that I've been talking. Now welcome any questions. Thank you very much.
Thank you, Dr. Agha, for excellent discussion. So I have a couple of questions. One is for you, and the same is for my colleagues in Pakistan as well. So one, and then I would like to share maybe two of my patients as well. So one question is about the monitoring schedule. So you mentioned about quarterly monitoring of your early high-risk patients in the first or second year. What about somebody who is 5 years down the road? What's your protocol? Do you do any annual monitoring for the viral load or not?
No, I think so whenever you're devising a monitoring schedule, and this is my practice and it may be completely wrong, but when you're devising a monitoring schedule, you have to kind of figure out what the bang for the buck is, right? And so essentially, what I do is I monitor them quarterly for the first year and then every 6 months for the second. And the first 2 years is the first peak where you see the highest incidence of EBV positive PTLD. And after that, we just go with a for-cause strategy. At least I go with a for-cause strategy. Some people check EBVs forever, with on an every 6 month schedule. But my feeling is that your bang for the buck is the greatest in the first year, maybe in the first 2 years, after which the EBV positive PTLDs taper off and your late PTLDs, the non-EBV PTLDs start going up.
Thank you. And how is this? Let me ask my colleagues from Pakistan. Anybody? How do you manage this, or do all the monitoring? Do you check the viral loads or any antibodies or anything?
Okay, so I was just actually typing this into the chat box, so I'll just mention it here because so I can speak for our centers and definitely Sheikh Zayed Hospital where I've trained. We do not do any sort of EBV monitoring, let alone we don't even do it as a part of the pre-transplant workup. So my question actually, which I was putting in the chat box, was that is there anyone doing EBV monitoring or even as a part of their pre-transplant workup in Pakistan? I am not aware of any program who is doing it, but maybe someone else can tell them. I see Zahid Farooq Beg is here from CMH and maybe a few of my colleagues. But this was an excellent talk, and primarily the reason why I wanted to join was because I have never seen a case of EBV here, and the reason for that is that probably we're not even looking for it.
That might be one reason. The other reason is I think the demographics and epidemiology of EBV may be a little different in Pakistan than it is in the West. And it is entirely possible that exposure to EBV is much more widespread in the population at an early age. I think it will be very interesting once Zahid has opined. It will be very interesting to, if Dr. Lainwala is on the line, to see what the kid experiences. because this is a disease, especially the EBV positive early peak PTLD is a disease of the younger patient. So I'll give the floor to Zahid, and then if Dr. Lin
Yep. I mean, if there's anybody there who is doing, EBV monitoring or as a part of their pre-transplant, kindly just raise your hand or speak up.
We do it for pre-transplant assessment, but as we do in adult patients only, and I have never seen a negative patient in all the monitoring what I did. So it is always, or we have always patients who are EBV positive. Post-transplant monitoring we have not done yet. So this is what we do.
And that's what my suspicion was, that your IgG positivity is so high that you're not going to get the positive to negative patients that frequently. But the ones who are going to develop the lymphoma, and luckily, the incidence is 0.5% in the first year, so it's not a very high percentage. But the one that's going to develop is the guy who's going to be the 1% who didn't have the IgG. But again, you have to, in a resource-stretched environment, you'll have to see if 99% of the people are positive, then running that serology, and everybody wants to bang for the buck. So that's an interesting question to ask.
So may I just ask a question at this point? So essentially, this is what we see with CMV in Pakistan as well. I have yet to come to see any donor who is IgG negative. All patients, recipients and donors are always positive, and that's why you give them the prophylaxis. So in a setting where, so the question is twofold. One is that if it is a positive to positive, donation, if that is what is happening, so in that case, T cell depleting therapy is not a problem in that case, isn't it? Because we were thinking of negative to positive, isn't it? Or positive to negative, I'm sorry. And in terms of clinical presentations, we did touch upon a bit of, so these lymphomas or these PTLDs just present like any other malignancies like fever, weight loss, and that is when, you start thinking on those lines, or is because it's, as you said, it's extranodal. So I would imagine, looking for lymph nodes would, won't be that helpful. So is it just like you start thinking of hepatosplenomegaly and fever and things like, when we start thinking of TBs, actually, we should start considering PTLD as well?
100%. I think if I would sum it up in one word, that's what, if you're thinking in terms of a presentation that sounds like consumption, constitutional symptoms, and, the presentation is different in intense mononucleosis syndrome. In adults, it's more of a progression where you can actually have mass lesions, you can have constitutional symptoms, fevers, weight loss, fatigue, etc., but it's not as acute as in the children. Those are the patients where, when you're thinking about, oh, does this guy have TB? Does this guy have something else? You need to have one bulb on your radar. Could this be PTLD as well? And if things are not getting better, and you don't have an inordinate amount of time, so this is not a person, I would say, come back in 4 weeks. If they've got lymph nodes, which about a third of those could have, if the imaging is abnormal, you need to get on top of that very quickly. And, if you're checking other things at that time, and if it looks like something more than just, the occasional fever that everybody gets, or a UTI or something, I would check on EBV PCR, but I understand that everything that you do in Pakistan, especially, which is a molecular test or something, is very expensive. So you have to kind of pick your battles. And this is where you guys are actually much stronger than us. Your clinical expertise and acumen of looking at a patient and saying, this guy looks sick and this guy's probably okay, is how you would actually be doing it, I think, because if you had all the resources, you'd be doing the test, right?
So maybe Ahad, if I can present, like I share one of my patients, actually 2 of them. So a young guy in his 30s, high risk to develop based on his serological status. So one day he came to the emergency room with the constitutional symptoms, as you mentioned. So he had significant weight loss, and what brought him to the ED was really a flank pain. So this is very interesting. So he was having some GI symptoms, but flank pain. So when there was a CT scan done in the emergency room, which was super impressive in terms of really very large, bulky intra-abdominal lymph nodes and lymphadenopathy, and in the retroperitoneal region as well. So to the point that his native kidney was hydronephrotic. So one, I think right or left, one kidney has hydronephrosis, but his creatinine was okay because his transplant kidney was working. And he has really, like, lymph nodes everywhere in his chest cavity, neck, inguinal region. Those inguinal lymph nodes were super large and bulky. You can easily palpate. So he actually did not come to, he didn't bring this to anybody's attention. He was like, I think between 1 and 2 year time frame, and this developed very quickly. It was not a matter of like weeks to months. Like he said, like within days, he was feeling those bulky things. In the ED, I think, I don't know, somebody gave him a very grim picture. So when we were consulted, the guy was very depressed. So he was treated with rituximab, and very quickly, I think I've seen like what a dramatic improvement. So his, like, we didn't have to do anything for his obstruction. Within, days, he started to improve. So there was very rapid improvement. So we did everything in terms of, reduce his immunosuppression. We switched him to, I think, rapamycin at that time as well. We stopped his CellCept, gave him rapamycin, reduced his CNI. He actually recovered very nicely from this lymphoma, and salvaged his kidney as well. So that was one, I think, presentation I remember. All the patients I have seen in the transplant clinic, more than 50%, actually majority except 1 or 2 were EBV positive. And except this patient, I've seen them several years out. And interestingly, they were still EBV positive. So there was one patient I still vividly remember. He got 2 problems simultaneously. One was the PTLD, biopsy proven from the lymph node. The other was large crater ulcers from Mohs surgery, because he was getting very rapidly enlarging skin cancers, and every surgery was kind of causing a problem. So we were kind of stuck between, we cannot use rapamycin. So we had to kind of had the balance between some CNI, some steroids, and then we gave him rituximab, little or no response. He was the one who ended up getting the proper chemotherapy for lymphoma. With the I think he got one of the CHOP regimen. And you know what? Eventually, as the time went by, this was his second transplant, and he was with the second transplant more than 10 years out. So those was his risk for maybe skin cancers. He actually recovered, his skin healed, his lymphoma recovered, and he kept his kidney. So that was, I mean, we had to see him very often. He was a very challenging case, but eventually he recovered. Everything, turned around for him. So somebody who develops that, I think this is the lymphoma itself could be very devastating for them. So that has been my experience. I don't know if Zishan, you want to share yours, or Dr. Agha, if you want to share some patients of yours.
I would actually ask a quick question. Do you remember the first patient that you said who had the bulky lymphadenopathy? Did he have diffuse B-cell lymphoma on his morphology?
Yes, this is how it was. I mean, he had like a little bit more than, this was like not just the EBV kind of, there was EBV present, but he was very diffuse.
Classic monomorphic B-cell PTLD driven by EBV, and now you know the program, right? So this is the growth program going haywire. That's where the problem is, in the B-cell immunoglobulin rearrangement, which leads to lymphomagenesis. And like I said, these guys respond very fast. So these are not patients you want to sit on for long, because they go up very fast and get into trouble very, very quickly. And you don't want to wait, months to restage. A few weeks and you need to restage them. But oncology is usually all over these patients. It's not something that we are doing, but it's good to know, what's going on under the bonnet of that particular car.
Thank you. We have, I think, a couple of questions in the chat, and Dr. Afzal, he raised his hand too. Aurangzeb, go ahead, all yours.
Okay, assalamu alaikum. Once again, a great talk. Thank you so much. I think I already asked a couple of questions in the chat box, and one of them was, is it essential for rituximab use that the lymphoma should be having a CD20 positivity? And
If it's a B cell lymphoma, if it's a EBV positive or negative, doesn't matter. Rituximab works. If it's a T cell lymphoma, then I think they would go in for alternate forms of chemotherapy.
yeah, that was the second part of the question. If so, if T cell is positive, then we may think otherwise. Is that right? Okay. So for in Pakistan, let's suppose we are presented with a patient who is not having any localized symptoms, just constitutional symptoms, and we are thinking living in endemic area for tuberculosis. And usually the workup is not that yielding sometimes, and multiple prescriptions and controversial opinions regarding TB trial should be given. ATT is usually tried on those patients. Like there is TB, but it's not being discovered in investigation, so you should use ATT. That's not really uncommon. I don't think this is a practice to be advised, but this is how it is. For patients like these, do you advise a pan CT or a PET scan, or how would you investigate him in this situation?
Well, I mean, it depends on the clinical situation and your index of suspicion. So if you've got somebody who, so the things that you have to worry about in these patients is they present pretty much like somebody with TB would present. They present pretty much like somebody with a disseminated fungal infection would present. They present sometimes very, very similar to someone who's got cancer from another source, right? So our transplant patients can develop cancer from multiple sources. They can get cancer which is de novo. They can develop cancer that was overlooked during their workup, and now it's presenting. They had lung cancer we never found out, just a chest x-ray, and now you've got a gumba in the lung. Or they may have a donor-derived cancer, that something was transmitted, myeloma or even lymphoma was transmitted from the donor. We didn't know that the donor had a problem, and we've seen donor-derived malignancies in kidney transplant patients. So this is a difficult diagnosis. It's not as easy as I made sound, that somebody comes in and they've got lymphadenopathy and fatigue, and voila, you've got PTLD. So you have to go through the entire diagnostic process, and you have to exclude infection, because Jesus, if somebody's got TB and you give them rituximab and CHOP, now you're working with the mycobacterium, not against it. You have to make sure that there's no infection. You have to make sure that the cancer that you're talking about is a PTLD. Once you've got the diagnosis of PTLD, then you stage it. So PET scans and pan CTs and all that are part of a staging exercise. But the first thing you want to do is to make a diagnosis, right?
Yeah. Let's suppose if the tuberculosis investigation is negative, bronchoalveolar lavage has been done and it's negative, but there isn't any lymph node, the patient is having constitutional symptoms still, and you start to think like it's PTLD, what should be the next step in this situation?
Well, in that situation, if you've imaged them and you don't find anything, and they're still are pretty symptomatic, and you've excluded infection, you've excluded the cancer, I think checking an EBV PCR is probably a good place. If the EBV PCR is positive, then you can follow that. And sometimes the EBV PCR, if it's going up, if the imaging was negative at one point, and I'm talking about the early spike of lymphomas, the next imaging might catch it. So in my practice, if somebody like this came to me, young guy with a high risk for EBV, right? Seronegative, getting a seropositive organ, the moment they come into the door and they say, my throat hurts and I've got a fever, I'm checking an EBV PCR, because that's my number one diagnosis. But that doesn't mean that we don't see TB. That doesn't mean we don't see other things. But I'm just telling you, now, this is a guy who's 10 months out and was EBV serostatus positive at the time of transplant. And he comes in and I've got a sore throat, I'm giving them amoxicillin. So, the index of suspicion sways significantly with their risk. So I don't run after every fever, but in the person I'm worried about, I really look at it. So when you're screening, you can't do everything for every patient all the time. you'll just break the bank, even in America, especially in Pakistan. So you have to channel your energy to where you're probably going to find something, or you're much more likely to find something. So I distinctly, when I was talking about this, I distinctly remember this, that there was a young kid, 18, 19 years old, seronegative, who actually got CAMPAT. He shouldn't have gotten it. He got CAMPAT. So we were all worried about him, and we were checking EBV PCRs, and he comes back 3 months, the 9-month visit, coming back for the 12-month visit, and he had his hand here. And as soon as he walked into the door, I said, get into the CT scanner now. So, in a person that you're worried about, that's how you respond. But if this was somebody else, I'd say, oh, maybe he's got a tooth infection, right? But in this particular case, it was all of our backs of mind that he's going to be high risk. He did have a lymphoma. We did treat him. He's fine. But that's kind of the way you would channel your index of suspicion. In the end, you're right. This is a gray diagnosis in many cases, even with the resources that we have in the United States early on. Once you've sat on it for 8 weeks, then it's not gray anymore. It becomes very black and white at that point. But at the time where you can actually make a meaningful difference, it becomes a very meaningful diagnosis. So just to make a point, what I would do in this situation, the gray situation that you're talking about, somebody coming in with constitutional symptoms, have got a positive EBV PCR, I can't find it. I will lower immunosuppression, right? That's how you would treat something which is not bulky at that time. You lower immunosuppression. And if the EBV PCR goes away and their symptoms get better, I'm like, okay, we're getting somewhere, right? On the other hand, if the EBV PCR is going up and now they've got localizing symptoms, now you've got a target. You know where to go with that.
Thanks a lot.
Anybody else who, Ali, if you want to share something, if you're still here, Ali Ashraf, about, if you experienced some PTLD while you were here. I'm not sure if he's okay. Go ahead.
No, yeah, we were part of a private group, and I did not get to see many post-transplant patients, so my PTLD experience is very limited. Okay. But this was an excellent talk. Really a learning experience for me.
Thank you. Any final questions or comments before we conclude the session today?
I do have, this is not related to this, but, there's a new research coming in the association of MS with EBV, multiple sclerosis with EBV. What is pathophysiologically, does it make sense, Dr. Aga?
Yeah, so it's, EBV, chronic EBV stimulation, which is sometimes called the chronic active EBV infection, has been associated with several autoimmune neurologic lupus. The thinking is that it's just chronic stimulation of B cells, which leads to autoantibody generation, and they essentially have an off-target effect either on neurologic or renal or other tissues. So there's all sorts of associations with the chronic EBV stimulation of the B cell repertoire.
Thank you. Any other questions? It's like, I think we are coming towards the end of the session. Thank you, Dr. Agha, for, again, a wonderful talk about, a condition which, in my mind, is if there's a lot of bang for the buck if you can diagnose the right person, because the treatment is available and it's life-saving. So thank you for sharing your thoughts.
Thank you, everybody. Have a good day.
Thanks.